Okay, so welcome back to our Friendly Circle Berlin Monday workshop group. My name is Patrick, and today we're covering the subject matter of ADHD and addiction and the link between ADHD and addiction. And for this presentation, we are delighted to have Dr. Timothy Wilens with us. And Tim is the chief of the Division of Child and Adolescent Psychiatry and is co-director of the Center of Addiction Medicine at Massachusetts General Hospital. He is MGH trustee chair in addiction medicine and a professor of psychiatry at Harvard Medical School. Dr. Wilens has dedicated his career to understanding the interconnections between attention deficit hyperactivity disorder, ADHD, bipolar disorder, and substance use disorders. His groundbreaking research has shed light on the effective treatment approaches for individuals experiencing these co-occurring conditions. And I'm really delighted to introduce Nick Pairaudeau, who is somebody that I met in London at our annual conference last year. And Nick's doing wonderful work on bringing this kind of knowledge and healing for this situation to the recovery community. Comes out of the 12-step community, and like myself, and he has started a group in London, which he'll tell us more about, and then he'll go ahead and introduce Tim and get this ball rolling for us. So thank you so much, Nick. And I'll put information on the ADHD Action Network, which Nick is the founder of, in the chat. Thank you, Nick. I'm going to turn it over to you. Should be able to unmute. Asking you to unmute.
Check, check. Can you hear me?
Yes. Thank you, Nick.
Yeah, I just want to start with saying I'm so lucky to be able to speak to everyone on the call, and Pat for sending this, and you know, Tim as well. Our history sort of intertwines. About a year ago, I reached out to Dr. Wilens, or a year and a half ago, after I had been diagnosed with ADHD, after I've been in the program, the AA program, for about a year and a half. And it was really interesting. When I went and saw the psychiatrist, he told me, and we're very lucky to have a psychiatrist here. So I at the time, these, you know, questions that I've got now have matured a lot. But the doctor told me that I had been medicating myself, the psychiatrist, when I got my ADHD assessment in London. And it was a really interesting, it was the most interesting piece of information I got from the diagnosis, you know, which was a 2-hour in-person, you know, they did the DIVA report and whatnot. So, but the most interesting thing I got out of this was that I had been medicating myself. He didn't feel I was an addict. I know that I'm an addict. If you open a box of chocolates around me, I'll eat the whole damn thing and I'll go back to the store and buy more. So my addictions are sort of all over the place. But I found that to be so interesting. Yeah. And so during this journey, I'd reached out to Dr. Wilens and said, I had this idea. If we were to take the 12-step program, I was to shrink it down to 4 steps, make it simpler, or 5 steps, and then sort of try to add some evidence-based research in there where we could take sort of the latest understanding of the neuro science around ADHD and apply it to sort of a program. What did you think? And he got right back to me, which was just, you know, such an inspiration for me to actually, you know, continue this, because everyone knows that it's not easy to run a program and to put one on. So over the last year, I've run 2 cohorts, and I'm now working with an NHS trust and working with King's College and UCL to help with the programming. And you know, I just want to say thank you, Dr. Wilens, for giving me the encouragement to, you know, try to move this kind of idea forward. So I'm grateful. I just want to say thanks. And so that's the beginning of our connection. And yeah, again, thanks so much. And again, yeah, that's basically it. Where I'd love to start, though, with that. And anyways, Dr. Wilens gave me the support and the encouragement. Yeah, I think this is a great idea. Move forward with it. We've done so. Um, Now that I'm further down this road, though, I've got so many more questions, as you probably do. Especially the way that addiction and ADHD overlap each other. And I'll start with the first question is well, let's start with what brought you to this, world of ADHD and addiction. I'd love to hear your story and your background of what, you spent a lifetime now doing research in this space. And I think we're seeing it more and more clearly how the two meet hand in glove. And a lot of the old timers in the program I'm in have said, oh, yeah, we all think we've got it. And these are people who've been sober for 30 years. So I'm going to let you take over from here. I've got some other great little questions to ask you, but I think best place to start is what's your history of these two intersecting?
Yeah, first of all, thank you, Nick, and for all of the organizational work you're doing. And sort of, it's always wonderful to hear people's journey through life and their sort of understanding of the journey and clarification of where they're at. And self-actualization is so powerful, absolutely powerful. One thing I always say as a psychiatrist to people is among the most powerful people in this world, at an individual level, are people who are self-actualized, who understand themselves and accept that. And once you do, others do, But to come back to your question, I've always been interested in, and also I wanted to shout out Patrick. Thank you, Patrick, for organizing and leading what seems to be an incredible group. So my journey was really, as a psychiatrist, I became interested in child because I realized pretty quickly that 50% of substance related or addiction starts in childhood, 3/4 by the age of 26. And I was very interested in what can you do to negate that? How do you stop that from happening? And then part B was I was always interested as a child psychiatrist. I worked with senior people, worked with ADHD. I one time went to a senior mentor and said, I'm interested in this very specific area. And he looked at me. He was a Southerner from the United States. So he had that wonderful draw, big guy, bow tie. No, not that I emulate that anymore, but and he said, y'all, why are y'all studying areas that are so sliver? Why don't y'all study a disorder that affects a lot of people? So I thought, you're right. And so I started working in the field of ADHD. I had a senior mentor, Joe Biederman, a real kind of figure in the field for many, many years. And, I had always been interested in addiction. I helped cover addiction units in the community. I'm kind of classic researcher at Harvard, but I also work in the community as a provider. And so I became interested and I started to see a lot of people who had both. And as a child psychiatrist working with adults, I could see it. And I worked with Joe Biederman and we started studying it. And all of a sudden, we were among the first to show, wow, there's super high rates. And I'll be happy to go through that in my slides and kind of walk through the evolution. And then it leads to other things. Once you start, you see it's the overlap's high, then there's a billion other questions that come up.
Yeah.
So should I start with the slides or do you want to go through your questions? I'm not sure how you want to.
Oh, no, let's start with a little bit of the
Okay.
research you've done over the years to show people the comorbidities. I think it's really important.
Okay. I'll do that and then either stop or I'll go through it and
Yeah,
then you'll have questions. So this is great, everybody. And thank you. And I'm going to share screen and get started. Takes just a second here. And there we are. Everybody okay? Any thumbs up there? So I see it's okay. Yep. Thank you. Great. So these are disclosures. Just I work with different companies. The funding for my laboratory comes from our National Institute of Health. And I also work with our Food and Drug Administration, and I'll show you some of those data. So we're going to look at the relationship, both directions of those disorders. Also, it's really important, how do you treat SUD as substance use disorders? Although I will talk about general addiction, but I'll be focused more on chemical dependency. And then also I want to talk a little bit, since we're talking about misuse, we use stimulant medication. Stimulant medicines are controlled substances. So what do we know about misuse of medicines that we use for ADHD? There's still a lot of questions. Do they cause substance use disorders? Do you giving kids methylphenidate, a controlled substance, does that increase the likelihood for them to develop it? So we'll talk about all of that. This is the world of ADHD. So you can see around the world in the blue, there have been studies of ADHD, and the prevalence of ADHD in kids basically worldwide is in the 6 to 9% range, and is in the 4 to 5% range in the groups of adults. And that number's clicked up just a little bit more recently. So we know that it's a chronic disease. That is that about 50% of kids, 1 and 2, will continue to have it into adulthood. Some people think that figure is off. Some people think it's much more frequent that it goes into adulthood, but it's at least 1 and 2. And then there's high rates of other things called psychiatric comorbidity. These individuals with ADHD also have depression, anxiety, substance use that we'll talk about. And some of it is probably genetic, and some of it is, if you don't treat ADHD, you can get demoralized and depressed. ADHD has a lot of impairment. So a lot of people think it's a cosmetic disorder. Oh, it's funny. Well, it's fun to be around people with ADHD. I absolutely adore and love working with people with ADHD. Lots of laughs and stuff, but also lots of tears. And there's impairment. It's not fun to have it. It slows you down. I could go on to the million impairment things, but it's hard. The diagnosis we make of ADHD is not by testing. You do it by just clinical assessment, and you can ask a lot of questions about symptoms in childhood and symptoms currently for inattention and distractibility, and there's 9 in that area, and then hyperactivity and impulsivity, and there's 9 in that area. And you have to have a certain number of those symptoms present in childhood, present currently. Can you develop it late in life? Not really. It's probably something else. Doesn't mean our treatments won't help that, but it's probably not ADHD. And finally, this isn't a lecture on ADHD, but I want to let you know, one of the just things I love about ADHD is that it responds really well to treatment. Now, you may not find it on the first shot. You may have to try different things or combinations of things, medication, psychotherapy, combination. But if you keep trying, almost always you find treatments that work really well. Now I'm going to reverse this and start with substance use. So this is now in adolescence rates of, and you can just go all the way to the right over any substance use disorder. And the rates are about 1 in 10 adolescents develop a substance use disorder by the age of 18. That's why I started with adolescence, because it starts early. And if you go to age 26, then about 3/4 of those people who ultimately develop a substance use disorder will have developed it. Now, I'm interested in the overlap with ADHD is ADHD onsets by about age 3 and substance use by age 18. So you have many years to see if you treat ADHD or the comorbidity, does that reduce the risk for later substance use? You have time to intervene. So what is the overlap? So if you're sitting there with ADHD, this is the overlap of substance use disorders, SUD, substance use disorders. If you don't treat ADHD, by the way, this is untreated. So about 50% of adults with ADHD who are never treated for their ADHD have a substance use disorder. It's a lot, half. If you start with substance use disorders and you're an adult, and you say, how many adults who have substance use disorders also have ADHD, you can see that it's about 20%. I'm going to go on and show you a little bit more. So this is an older study that we did, the first one that looked at different disorders, multiple drugs, opioids, cocaine, alcohol, and the rates of ADHD. Higher numbers are higher. And here you can see overall that, first of all, a little bit of difference. Alcohol, slightly higher rates than other drugs. But at the end of the day, if you look at that, plus a study that was done in the European Union that then Emmerich von Ostersen did, looked at the rates of ADHD in about 20 to 25%, 1/4 of adults who have a substance issue also had ADHD. That's a lot. Now, if you start with adolescents, this is studies of adults. If you look at adolescents, the rates are over 50%. Over half of kids with a substance use issue have ADHD. We're very fortunate. We have a wonderful outpatient young person addiction service. And we've done studies there, and we found 65% of our young people aged 16 to 26 who have an addiction also have ADHD. So the younger the addiction, the age of people in addiction treatment, the more rates or higher the rates of ADHD relative. But even in adults, one in 4 adults who have an addiction have ADHD. That's why we're talking about it. You know, that's why Nick is so concerned about it. That's why Patrick is having us talk about that today. Now, don't worry about reading this. And by the way, you can have all the slides. He's happy to send those on to you all, so you don't have to worry about taking so many notes. I just want to point out that this is even in very serious addictions like opioid use disorder. So this is a study we did, opioid use disorders. Just want to point out, from 2007 to 2017, over a decade, the diagnosis of ADHD, this is opioid use disorders, people with heroin, fentanyl, or other synthetic opioid who misuse those. It used to be about 5% diagnosis of ADHD, but in 2017, it went up to 15%. Half of those with ADHD and opioid use disorder are being treated for their ADHD, and stimulants are used in about 11% of those receiving medicines for opioid use. So this even applies to people not just with alcohol or marijuana, cannabis, but people with serious opioid use disorders. So what do we know? Let's talk a little bit more about the relationship from ADHD standpoint. When kids are growing up with ADHD, these are among the first studies that showed that you're at an increased likelihood to develop cigarette smoking. And how much so? About a 5-fold increased likelihood to use cigarette smoking. And now that, you know, people are vaping and we're seeing our cigarette smoking decrease and our vaping increase, we're seeing the same thing with nicotine vaping. And this just shows you the actual data, but a big risk to develop a nicotine disorder if you have ADHD as a child. But what about substance use? Not as big a risk as cigarette smoking is and nicotine use, but still about 2 to 3-fold increased risk for the development of a substance use disorder in ADHD kids growing up. So anytime I'm sitting across from a kid with ADHD, I talk to the parents and I talk to the kid about the increased risk for addiction and the need for them to be very careful when they're using any addictive substance, and even experimentation with alcohol, nicotine, etc., because it's easier when exposed to any substance to then become addicted. And there's some data that shows that your reward center, how much you like the drug, is different, and that you get addicted at a much more rapid pace to it. So let's talk a little bit about vaping in ADHD. So there's high rates of nicotine use and vaping in ADHD compared to those who don't. Higher rates of ADHD and e-cig use. So e-cigarettes are just vapes or inhaled nicotine using a fake cigarette or a synthetic cigarette. But we see just very high rates of ADHD. And this is what I was talking about. My friend and colleague, Scott Collins, did some very interesting work on that. And what he found is that the reward system seemed to be different in individuals with ADHD compared to them. That's in the brain. In other words, they have more pleasurable experiences. I really like nicotine. It turns me on. It makes me feel good. And there's no difference in the unpleasant experience. So most drugs have both pleasant experience and unpleasant experience. Think about yourself when you've been on that path. I don't need to tell you, many of you are in recovery and you've lived with both the delight and the experience of the high, the euphoria, the feeling good, but then also the dislike, the dysphoria, the shame, and all of these other things that come along with using it. What they find in ADHD is that the pleasurable experiences are really increased and not the other ones. And then the other issue, and Nick talked a little bit about self-medication, that is using drug or alcohol to help kind of reset yourself. Well, there's a lot of data, and I've done a lot of studies looking at nicotine or nicotine-like compounds to treat ADHD and or some of the cognitive thinking problems that you have with ADHD. So nicotine in hand does improve cognition, and it really does. And some people, say they started because of that. And I want to talk a little bit about a complicated course of substance use, because what we know is if you have ADHD and substance use, if you're sitting across from me right now, you probably can give this part of the lecture. There's typically a more severe form of substance use. There's higher rates of other problems associated with the substance use and the ADHD. So it isn't just substance use and it's ADHD, more conduct disorder, more antisocial disorder, more anxiety disorders, more depression. So it isn't usually just ADHD and substances. There's something else there. It's harder to get better. Remission is getting better. It's harder to get better from your substance use, either in treatment or if you're just in the general community. We studied this years ago in the general community. There's a longer course of substance use. That doesn't make any surprise. If it's harder to get better, you're going to have a longer course. How much longer? In the general population, for people who got better on their own, they lived with an addiction twice as long. Twice as long. So instead of 5 or 8 years for many of them, it was 16 years. That's a lot. Another important thing is lower retention and treatment. That's huge, because we know, and you know, that if you stay with treatment, if you go to AA, if you go to NA, if you are part of a senior counselor, if you're taking your medicines, you're going to do better with your substance use treatment. And if you have ADHD, you're less likely to stick with your treatment. I also want to talk, and I said I was going to generalize this to general addiction. So let's talk a little bit about an area that really hits hard that we don't talk much about, which is internet gaming addiction. On the internet, gaming. There's higher risk for internet gaming addiction in ADHD. And this is an older study now, but of young adults and controls. And what found was that there's a high risk for ADHD compared to the controls. And in those individuals, prominent impulsivity, hostility, you see the kid with the controller, throwing the controller at the screen, pushing over the things, screaming, really getting dysregulated. And I wanted to move forward to talk a little bit about why is it? What's the neurobiology? So this is a picture of the brain, and it would be like this, front and back. And that over here is the front of the brain, and this is the back of the brain. So if you put your hand over your forehead like this, your hand would be here. So this is what we're talking about. Addiction is very complicated neurobiologically. So in a very reductionistic way, trying to give an understanding of where addiction is, why it lives, and why do we see higher rates in ADHD. So this here deep, this area here, and by the way, this is where marijuana, if you give radio-labeled marijuana, that's actually radio-labeled marijuana. That's where it lights up. But these areas of the brain are involved in reward. I could say the sex, drugs, rock and roll center of the brain, okay? Everything you like, everything that turns you on, this part of the brain lights up. But it's also part of the brain that's involved with anxiety and mood. It lives over here too, and you can see the interference there. And then finally, memory. So no surprise, people have blackouts, they drink too much, whatever, they can't remember certain things. Well, it's because your reward centers are really close to your memory centers. This part of your brain starts very early in development. Think about kids with sugar. Well, it doesn't take long, and kids love sugar. And this part of the brain turns on, and they don't have the capacity not to want and grab sugar. If you leave cookies, they're going to eat them. Now, this part of the brain is later developing. This is the part of the brain that develops till age 25. It's part of the brain that's involved with inhibitions, and it is part of the brain where ADHD is thought to be the most problematic. Again, this part of the brain. And this part of the brain is where kind of your inhibition center of the brain. For example, depending where you are in the world right now, you may have had dinner and you were thinking of having a dessert, or you may have had lunch. And your decision about that is your reward center is like, yes, definitely go. And those beautiful fudge things that you have sitting out on your counter, you should have another one. That's your reward center saying, yes, definitely want more. This part of the brain says, no, you'll be on an elliptical trainer, or you'll be exercising for an extra day if you eat that. So no, you don't want to eat that. And this is saying no to that. Addiction turns this on. And when you have ADHD, this is not strong enough to tone down the addiction. And it's delayed in its development in kids with addiction through adolescence. So this part is not fully developed, and it's even later developing in ADHD. When we treat addictions, we do it different ways. Psychotherapy, etc., helps with inhibitions, and giving meds for ADHD helps with inhibition. It helps strengthen this to shut that down. When we give medications and we give therapies that keep people away from areas that they use, that helps treat the reward system. So that's sort of why this happens. Now, one of the biggest points, since we're talking about kids, is does treatment of ADHD in childhood impact later substance use? And this is from a study we did where we looked at the world literature for all long-term outcomes in ADHD. So I'll spare you all the methodology and stuff. But what I wanted to say is that there have been really 4 big studies. Look at the sample size in this one in particular, 3 million, but there you've got, almost 40,000 in Sweden, 20,000 in Denmark, and a smaller study in Sweden. In general, when you follow people from early childhood into adolescence or adulthood, some of these follow-ups are, 15 to 42, 8 to 46. This one followed up 11 to 20 years. What you basically find across the board is down arrows, almost across the board, especially in the largest studies. You see reductions in the risk for substance use, especially during treated times. And if you look between groups that never received treatment versus were treated, you see almost a 50% reduction in the risk for substance use in treated ADHD samples growing up into adulthood. So treatment early, even with stimulants, which are controlled substance, reduces the likelihood for a substance use disorder. This is a really interesting study. I worked with a colleague of mine at the University of Michigan, Sean McCabe, who's an incredible psychiatric epidemiologist. And he asked the question, if you look at just marijuana use in 18-year-olds, this is the risk of use in the past year in the general population. And look at this. If you start stimulants prior to age of 9 and they're on them for chronically, over 6 years, this is not any different than that. It looks a little bit higher. It's a little bit higher, but it's not statistically, marginally higher. The problems you run into is if you don't treat ADHD and you wait to start the stimulant between 10 and 14 years of age, and look at the rate starts to climb up, or you wait until they're over 15. Now, what we don't have is just the ADHD group, but we do know that in general, it's about twice the risk. So we would estimate that it would be somewhere like right around here, the rates of ADHD using marijuana if without treatment. But the bottom line is the longer you delay the onset of treatment, the higher the risk for substance use. And look at that, prior to age 9. So this isn't a lecture on ADHD, but it's very helpful in terms of knowing when, if you're, like myself, and when I lecture to ADHD groups, really want to start treating prior to age 9, because that's where you get the most risk reduction. And by the way, this isn't the only study to show that. Let me go back and do this. There we are. Now, there are a number of diagnostic dilemmas. Since this isn't a provider thing, but I just wanted to let people know that overall, there are some overlaps, but one of the things I wanted to say is that one of the biggest things people concern about is do people with substance histories reporting on themselves under or over-report? It turns out they tend to under-report their symptoms. They don't make up the symptoms just to get stimulants. That's what a lot of people think. And that they tend, like most adults with ADHD, can't remember their childhood, so they under-report. One of the things we do recommend is if you're in an area, you can get rating scales about ADHD. If you think you have ADHD, you can go online and there's a number of rating scales. The World Health Organization offers them for free, and you can do a self-report. You can just take a look and check it off. And, do you currently have these kinds of problems? And it lumps it. And if you're positive on the screen, do the rest of them. And that would be something that you could report to one of your providers. Another thing is marijuana. So marijuana is huge. It's the most common drug misuse. If you reverse it and ask people with cannabis is the active constituents of marijuana, cannabis use disorders, ADHD is the second most common comorbidity. And cannabis itself is associated with neuropsychological problems that can overlap with ADHD. There's no evidence of more self-medication versus non-ADHD. So when you hear that, it doesn't mean you're not self-medicating. It means that there's not a preferential self-medication with ADHD. We have data to support that a lot of substance uses, there's self-medication. There's a ton of self-medication. So I don't want to say that self-medication isn't there, but it doesn't differentiate people with ADHD from others. And then can you use cannabis to treat ADHD? I have to tell you, a lot of my patients who smoke marijuana claim that it improves. And they actually did a trial over in Europe, small trial, 30 adults, crossover study, means for a period of time they're on treatment, period off. They used a 50% THC, which is the part that gets you addicted and it also makes you high, and the CBD, which is not addictive, but maybe more medicinal. And what they found was there was no overall cognitive or activity improvement in ADHD. So the main findings weren't. But if you looked at the secondary, you saw a hint of improvements of inattention. So overall, not a lot of studies, but the studies that seem to be out there don't seem to show that marijuana really treats that. And then I want to move on to, so what do we do for people, ADHD in adults who are presenting for treatment? So how do we handle that? And overall, if you have no substance use history, this is what the streetlights are and the stoplights in the States. It's green, do whatever you want. If you have a substance use history, yellow means you need to talk to people. So if you're getting treated or you're treating somebody, you're going to want to talk about your recovery and substances. It's fine to go ahead and treat with whatever, but I would keep an eye on that. Certainly ask people to monitor their use of alcohol and or drugs. And if they get cravings or urges because of the treatment, then to let you know right away. So we do that. And then we have the group that come in who have current substance use. They're using alcohol too much, they're using drugs too much, and they have ADHD. And so we're going to talk about that. First thing is, a number of years ago, we looked at what was out there. There were studies, and what we found from a psychotherapy standpoint was that structured therapies like cognitive behavioral therapy, very focused therapies, seem to help quite a bit people who have ADHD and substance use. And subsequently, there was a small trial that was done using a CBT, cognitive behavioral therapy derivative, that addresses substance use and addresses ADHD in individuals who had adults who had both alcohol or drug problems with their ADHD, and it worked. So one of the things that we strongly recommend for anybody who's in recovery who has ADHD and a substance use disorder is to think about using psychotherapy like cognitive behavioral therapy. Now, I commented early on that ADHD in context to substance use reduces retention in treatment, which means if you have ADHD, you're less likely to stick out treatment. So the question is, what happens if you treat ADHD? Does that reverse that? Well, this is data from Mass General, and this looks at two groups here. All of these people have substance use, all of them have ADHD. And this looks at the fraction of patients who are retained in treatment. So higher scores are better. This is 100%. Notice what happens if you don't treat ADHD. Look at that fall off, especially over the first 90 days. Probably surprises nobody. A lot of people drop out of substance use treatment. And then it continues. Look at this. This is out days after admission. I mean, this is 1 year, 2 years. We only followed the 2 years. But look at that. At 2 years, you're about 30% of your sample still there. Let's contrast that with ADHD. Most of these are receiving stimulants, but some non-stimulants. And look at that first retention out to 90 days. Very good retention out to 90 days in the blue. And then if you track the blue line out to that, by 2 years or 720 days, you've got 2/3 to 3/4 of your sample are still coming for your substance use treatment. So the treated ADHD group did much better in terms of retention in substance use treatment. So, and this was the first of a number of studies that have laid that out. Virtually every study since that has shown increased retention for people with opioid use disorder taking buprenorphine or methadone, for people in alcohol use disorder coming to their therapy, et cetera, et cetera. This is different now. This is looking at what happens when we treat people with active addiction. This is people with alcohol use disorder, still the most common, the highest, killer of people in the United States and worldwide with an addiction. And this is looking at heavy drinking episodes in people who are treated with atomoxetine, which in this country is Strattera, non-stimulant, and adults who didn't receive, who had ADHD and were receiving placebo. And you can see higher scores are worse, lower scores are better. And that atomoxetine had a significant effect. It reduced pretty substantially by about 30% the amount of heavy drinking episodes in individuals who have alcohol. So it worked. And for years, there were studies of stimulants, but at relatively lower doses because we were concerned giving higher doses to people with addiction histories, right? We're using a controlled medicine, amphetamines or methylphenidate. Those are the two major stimulants that are used for ADHD. And there was a lot of concern, and people did studies being very conservative with low doses. And they found mixed results, but one thing they said is promising outcomes need replication utilizing higher treatment dosing. And that's an important thing. If you're thinking being treated for ADHD, or you're treating people, especially in those with current active addictions, what do? So this was a very brave study done by my friend and colleague over at Columbia, Frances Levin, and she used higher dose mixed amphetamine salts, amphetamine, 60 and 80 milligrams, much higher than FDA approved dose, almost twice our approved dosing in patients who had ADHD, OUD, and cocaine use disorders, not uncommon. So they had ADHD, and then from a substance use perspective, they were all receiving methadone for their opioid, but they also had a cocaine use disorder. So they were focused on the cocaine use. Let's look stage left here, ADHD response, and higher scores are better. And here you can see that 60 and 80 milligrams was significant over placebo. Now, it wasn't dose related. You'd expect to see this higher, but that happens sometimes. But they worked. It worked. You see good response rates for ADHD. But what was even more surprising is if you look at cocaine use. So in this case, higher scores are worse. This is the number of positive cocaine urines. So that means you have cocaine in your urine. Almost 100% with placebo. And see how it drops down at 60 and at 80, a dose-dependent reduction. So it improved ADHD and it reduced the substance use, in this case, cocaine use, over the 12 weeks or 13 weeks of the study. And this is another study done in Europe where they looked at people who are incarcerated for drug use disorders, almost all amphetamine use disorders, and they were treated with high-dose methylphenidate. This is an extended release form of methylphenidate, mean dose of 108. So that's a pretty robust dose. And what was interesting is that when they look over time, the ADHD got better. So this is looking at ADHD, lower scores are better. This is the Conners. People have heard of the Conners scale maybe. This is what happens with placebo, not much. And with treatment, it really helped drive down the symptoms. But over here, even more findings. First of all, significantly higher proportion of negative urine screens, which means people did better. They didn't have as much amphetamine or other drugs positive in their screen. They were staying sober or abstinent, and they had better retention in treatment. So again, that better retention, but now we're showing reductions in the likelihood to use in people who are in recovery. So that's a good sign. So what do we say now for people with ADHD and substance use? In context to substance use, ADHD treatment should be considered. You need to think about it. If, let's say somebody is misusing or less severe substance use, or smoking, MJ We use that for marijuana. So they're smoking a couple of times a week. Do we worry about it? No, we treat. If it's more severe substance use, you're smoking marijuana every day, you're drinking, 6, 8 a day, you're drinking a pint of hard liquor, you're injecting drugs, all of those things. You need to address the substance use. You need to do something about the substance use. If you're addressing the substance use, you should think about all of those patients being in CBT, cognitive behavioral therapy, very structured therapy. Therapy was helpful, and a preliminary study shows that it does help. If you're thinking of treating ADHD, you can think about using non-stimulants or stimulants. Sometimes we use non-stimulants. You don't worry about them getting misused. They also help other problems. Like a lot of these patients, as I said, have not only ADHD, and let's say they're in recovery from alcohol, they have ADHD, but they also have anxiety disorder, or they have depression. Well, some of our non-stimulants can both address the depression and the ADHD. So we do it for that also. If you're using stimulants, and I'm going to talk more about that, we talk about using stimulants, we strongly recommend extended release stimulants, the long-acting ones. Why? Because they tend to be a lot less misused. And the people who misuse them, no surprise, are people who have substance histories. We try to be very careful with the short-acting stimulants because it can become a cue to you if you're in recovery. And it tends to get you a little bit, it gets you, they fast act on, fast off, and people say that it's too close to when they were using. So we try to avoid those. Plus, they tend to get misused more. What do we know about that? So I've been making comments about it. First of all, we know that in the United States, at least, pharmacotherapy for ADHD is up pretty dramatically. So the green is stimulants or non-stimulants, the red are non-stimulants, and the blue is stimulants. Everything is up right now. So there's more stimulants being used right now. Another thing we know from older, but it's still very helpful, is when we look at misuse of stimulants, at this age, almost 10 years ago, was about 10% of the population. But notice the age. If you focus on the middle of this, it's about age 20 to 22. So it's a young person misusing prescription stimulants. And you'll hear me use non-medical use or misuse. I mean they're similar. But people who misuse prescription stimulants are typically in this age group. And some of that misuse is people in whom it's prescribed. Some of that is people sell it to other people. And a lot of it is in people don't have a diagnosis of ADHD, but they're getting the meds. Either they're giving them or they're buying them from other people. And that just gives you a sense. There's been a lot of studies, about 10 to 20% prevalence in non-medical use, high rates on college campuses, lower rates if you look at the trades, people who are kids who are that same age and doing electrical work or plumbing or working, they don't have the same rates. It's lower. People who misuse stimulants, especially college age students, are really not scamming local practitioners. They're getting them from other people, or people are overprescribing them to them. And then they have these big, you'll hear me say this again, this collection of the stimulants that they can give to other people or sell. And when you ask people who misuse stimulants, I've done these studies, and you ask them about, are they potentially dangerous? No, they're safe. They're absolutely safe. They give them to kids, and people, I have friends who are taking them. So how can they be unsafe? I put this in because this is important to see that this is what's happening with non-medical use. More recently, I've already showed you this, that stimulant use is on the increase, but non-medical use is actually on the downside. It had sort of bumped up, and then it's been on the downside since the pandemic of COVID. And this is looking at people in whom it's prescribed who are misusing, and that's, thank God, it's a low rate, but it's also kind of trending down if you look. So non-medical use of stimulants is actually down. What do we know about people? Well, the most common reason for people to misuse stimulants is to help them concentrate or focus, to help reduce their distraction. And then you have some who use them to just stay awake, because one of the side effects of stimulants are they're stimulating and they can keep you awake. So that's the reasons. If you come down here lower, now you get into the group that probably have higher rates of substance use along with their stimulant misuse, to have a good time with my friends, to feel good, to get high. And then a small percentage who are probably depressed and just use it to get through the day. And what's the biggest motivation? Again, this is another study. This isn't the study I just showed. It's cognitive, sort of a cognitive enhancement to help people stay focused and not be distracted. And who's it? It's young adults more than adolescent. It's college students, kids in secondary schools. It's linked with other psychiatric disorders, suicidality. That's a big one. And substance use disorders. You'll see that over and over. I'm not going to go through this in detail. I'm just going to say we looked at this because there's so many people say that stimulants really are cognitive enhancers. But when you really look at the data, all the studies that have looked at it, and these are these studies, you see minimal improvement, no effect, some no effect. And most of the effect that you do see is expectation. If you tell people you're going to give them a stimulant, it's going to help them focus, they get better, even if they get placebo. So we call it expectation. There's a big expectation component. So where are people getting them? And this is what I wanted to make really clear. This is a much bigger issue, I think, in the US, where we are now able to give 60-day and even 90-day supply, 3-month supply of stimulants at once. Those who have reservoirs, that is, let's say you give somebody 30 tablets or capsules of a stimulant, amphetamine or methylphenidate, for a month, and they only use 20 of them, then they have 10 left over, and that becomes a reservoir. And the more they have left over, the more likely they are to sell them to somebody, give them to somebody, or misuse them themselves because they have extra supply. So it's excess that seems to be driving that. And as I said before, this is a little complicated to show the data, but when you look at what else, other disorders you have, this is looking at stimulant misusers and rates for substance use disorders. Almost 50% of people who misuse stimulants non-medically have a substance use disorder, and that's much higher than the general population. This is brand new data. This was just presented to our Food and Drug Administration, and it's asking an important question. And that is, if you treat adults with ADHD with stimulants, use new onset, so these are adults who start, and you give them stimulants, does that increase the likelihood that they're going to develop a substance use disorder? In other words, we have lived through that with prescription opioids. There's real concerns that if you give people prescription opioids, they have higher rates of opioid use disorders. Those are the people who ultimately went on to misuse their medicine and or develop a heroin or fentanyl use disorder. And a lot of people are concerned, is that happening in adults? And remember, I showed you that slide a long time ago of Dr. McCabe's that showed that if you wait and start treating after the age of 15, the rates of marijuana use were a lot higher than the population controls. And the question is it untreated ADHD, or is it that you're giving stimulants to older people and they're misusing them and it's triggering something? And I just wanted to show, this is an electronic health record data, 25,000 individuals, mean age 31, follow-up of about 2 years, roughly 2 years. And this looks at the treatment type here. So stimulants, non-stimulants, stimulants, non-stimulants, no treatment. And this looks at the rates of the rates of substance use. I don't know why, or the percentage of adult patients who develop substance use disorder. So it's the rates of substance use. And what I want to show you is that if you look at stimulants, they're lower than non-stimulants. 11% of those people with non-stimulants developed a substance use disorder during this period of time, but only 7% of those people with stimulants. And if you look at the combination, it's even higher. This is the baseline rate. If you don't treat ADHD, about 13% go on to develop it. So this is the one that goes across. And what I want to just comment about is, if you look at that, clearly stimulants aren't leading to substance use disorders. nor non-stimulants we have any reason, and probably not stimulants and non-stimulants. This is probably, there's a reason you're on these, you're probably a little bit sicker. So in fact, treatment of ADHD with stimulants, starting somebody in adulthood, doesn't increase the likelihood for a substance use disorder. Now we're looking at this in people who previously had substance use problems, and we're going to reanalyze all these data. So you're asking about people who are in recovery who then get stimulants and we follow over 2 years. We don't know that answer yet. We know over in clinical trials, it never makes it worse, and it seems to improve it like I showed you. And then it does matter, without going into too much detail, this is just the basic science. I just want to show you, we actually have basic science that shows you, if you look at immediate versus extended release stimulants and how they bind to the brain, giving the same dose, they bind much faster. This is a lot faster and more, the short acting compared to the long acting. And if you look at likability, this is the scale that tells you how abusable something is. Higher scores means it's more abusable. This is what happens if you give short-acting methylphenidate, and this is what happens if you give extended release methylphenidate. And these are all, that's a big difference, by the way. So this is proof that giving extended release stimulants reduces likability. The other thing we've noticed is that if you look at misuse of stimulants, most of them is swallowing, but look at how many people snort it. They grind them and sniff them. A lot. And we learned about that group. We've learned that the lowest on the abuse liability scale of the stimulants are what we call prodrugs. And I'm not going to be too technical, but basically they're drugs that are not active until your body takes them, and then they cleave them, in this case, into methylphenidate, serine and dexmethylphenidate, and the body cleaves it. So it goes from inactive to active when it goes into your body. This is a amphetamine. This is called lisdexamphetamine. And again, the big drug gets into your body cleaves it, you get lysine, and notice this, amphetamine. And these have the lowest abuse liability, prodrugs. The other thing we've learned is a lot of people ask the question, if you give stimulants, are they going to develop a stimulant use disorder? And I can just tell you the answer is no. That's not what's happening. If you give adults methylphenidate or amphetamine, and then you follow them to see, did they misuse cocaine? The answer is no. This is population. These are treated ADHD, no difference. Methamphetamine use, population data, treated groups. Well, what are these? These groups had misused their prescription stimulants. Either they had ADD in the red, or they didn't have ADHD, or the bigger group out there who just got them. And those are the people who are at risk for cocaine and methamphetamine. It isn't people who appropriately take their medication. There's no indicator that it increases the risk. And finally, I just want to comment a little bit about telehealth. So most countries now are using telehealth since the pandemic to treat ADHD. A lot of people are concerned, does telehealth increase the likelihood that people are going to misuse stimulants because you're not watching them as carefully? So this was a study that just came out last week, and just want to show you, it's a study of telehealth versus in-person, pretty big sample size, age 12 to 64, new substance use at 1 year. And first of all, they showed that it's interesting, who uses telehealth? People who are sicker. You know, it's harder for them to get to their clinics, to their community programs, to get into the hospitals, if that's where your treatment is, and so individuals who use telehealth are sicker. Despite independent of that, substance use rates were the same in telehealth versus in person, especially when you accounted for psychiatric comorbidity. Again, the sicker population were using telehealth, so you would expect to see slightly higher rates of substance use with telehealth, and you did. The conclusion, substance use is not more frequent in telehealth, and because there was a trend, it wasn't statistically significant, but there was a blip, that increased rate in the 26 to 34-year-olds, we recommend monitoring young adults. So that just came out in paper, published. And then we asked the same question, and this was just accepted. So this is from a smaller sample, but we have more data from our own records here at Mass General Brigham. And basically just following people and seeing, did you develop substance use? Telehealth compared to in-person experience does not increase later stimulant use disorders, methamphetamine or cocaine, or other substance use disorder. So here you can see in-person versus telehealth. This is no substance use, only a small group developed it in person and a small group here, and there was no significant difference. So this is another study that shows no significant difference. And this is in press currently with the American Journal of Psychiatry. So these are some things, if you're a practitioner or if you're a parent, educate people about prescription drug misuse, talk about the addictive component. If you're treating or you're being treated for a substance issue and you have ADHD, think about using non-stimulants. Again, they work for ADHD, but they also help other things. And if you're going to be on stimulants, you really want to ask for extended release, or what we call prodrug in the United States. I know these aren't available in a lot of different European arena yet. They are becoming more available, but not in some areas. Don't overprescribe quantity. And if it's your child who has ADHD and you're worried about things, just keep an eye on their supply. Monitor it. Don't just leave pill things up there. Keep it locked. Monitor it, because they could sell them to their friends. They could misuse them, etc. Don't keep medicine in medicine cabinets. That's where people look for medicines. Keep them elsewhere. And I always say, for college students or people who are leaving, when kids are leaving, don't tell people you're on stimulants. It's nothing to be ashamed about, but don't advertise it. Because as you know, people who have problems with substances will hear you and they will come. And I haven't heard of it, where kids get over that, but they get badgered to sell theirs or etc. So I want to go to questions. ADHD is a risk factor for cigarette smoking, nicotine use, and substance use. Everybody with ADHD needs to be monitored, but ADHD also has to be considered in adolescents and adults who smoke cigarettes, use vapes, and or have substance use disorder. Treating ADHD helps protect against the onset of cigarette smoking, substance use, and you can manage it. Treat your substance use, and then quickly after, go after the ADHD. Non-stimulants, extended release stimulants. Those are going to be your things. And since these can be misused in high-risk groups, continue mitigation strategy. ER versus IR, educating, monitor, don't overprescribe.